Hi, this is Kay Afji, and I'm taping a lecture on the nursing care of patients with brain disorders. First disorder we're going to look at is the seizure disorder and epilepsy. The etiology is that seizures can be caused by brain injury, tumor, and elevated temperature, end-stage renal disease, poisoning, or epilepsy. And seizures occur when the brain is deprived of oxygen. Signs and symptoms we're going to discuss in just a couple minutes, but I did want to just let you know that there is a video on YouTube. If you go to the PowerPoint slides and you come to this slide, if you click on the link for types of seizures, it will take you to a YouTube video that will help you to see the different types of seizures that are actually being experienced by the persons on that video. Okay, partial seizures are also called simple or focal seizures, result from an abnormal localized cortical discharge. Level of consciousness is not impaired when the patient experiences a simple partial seizure. Partial seizures with complex symptomology may also be called temporal lobe seizures, and they usually originate in the temporal lobe of the brain, and there may be some impairment of level of consciousness, so the patient may not necessarily be aware of their surroundings. Partial seizures can be unilateral, with involvement on only one side of the brain and activity only on one side of the body. You may see things such as automatisms. It's spelled A-U-T-O-M-A-T-I-S-M, automatisms, which are repetitive actions such as lip smacking. Generalized seizures, there are different types. Usually with generalized seizures, the activity will be bilateral. The first type of general seizure is absence seizure. This one only lasts just a few seconds. It oftentimes will affect children. It's often misdiagnosed. Children will be described as daydreamers, that they talk off on tangents and things like that, but in reality they may be actually experiencing an absence seizure. A myoclonic seizure is where there's a jerking of a group of muscles. It usually occurs when the patient is awake, so that's myoclonic. And clonic seizure is where there's constant jerking of the extremities. Tonic seizure is the continued contraction of all muscles, and the body will become rigid. A tonic-clonic seizure is bilateral jerking of the extremities. The patient experiences loss of consciousness, may have tongue biting, and also may experience incontinence. Then an atonic seizure is the loss of muscle tone altogether. The patient experiences a total collapse, but remains alert and conscious through that type of generalized seizure. And then there's the infantile spasm seizure, which usually is caused by an elevated temperature. The condition status epilepticus is a prolonged partial or generalized seizure without recovery between attacks, so it's almost like a constant seizuring. Rapid, unrelenting series of convulsive seizures occur without intervening periods of consciousness and an absence of respiration. So this is an emergency situation because patients aren't able to breathe because of the constant seizuring. Irreversible brain damage can occur if the seizures are not controlled. Treatment of status epilepticus is care is focused on supporting vital signs and preventing injury. They may require intubation and respiratory support. The seizures themselves are usually treated with intravenous medications. Like I said, this is a life-threatening condition, often brought on by people stopping taking their seizure medication suddenly, and then the seizures are kind of a rebound effect from having their medication stopped abruptly. Diagnosis of epilepsy is based on history and the actual signs and symptoms of seizuring. Thorough physical exam is done. There may be EEGs performed to see any abnormal brain activity. Also, MRIs may be done. They'll also check for electrolyte imbalances, because some electrolyte imbalances can cause seizures as well. Again, the electroencephalography, or EEG, represents electrical activity within the brain cells and can help in diagnosing seizures. Treatment is to control or eliminate the cause. Anti-epileptic drugs and patient teaching must be done if we can't eliminate the cause. If the patient's condition is not responsive to anti-epileptic drugs, we sometimes start patients on a ketogenic diet, which is a high-fat, just adequate protein and low-carb diet. They found that that can be effective as an adjunct treatment for seizures. Other treatments, biofeedback, can be helpful, as well as surgery can be done if they can identify the area of irritable focus that's causing the seizure. If that can be eliminated, that may help to resolve the seizure episodes. What observations do we need to make while the patient is seizuring? The time the seizure began and the time it ended, what the patient was doing before the seizure, where in the body did the seizure begin, and what parts of the body are involved, which way are the eyes moving, are they constricted or dilated, do they deviate to the right or left, or do they roll up, which side does the head turn, does the patient cry out or scream as the seizure begins, is there evidence of repetitive movements such as lip smacking, chewing, grimacing, tapping, or pill rolling? Are movements bilateral and symmetrical? Is there any incontinence that occurs? Any frothing at the mouth or bleeding? Does the patient become apneic or cyanotic? Are there any changes in skin color or profuse perspiration? The postictal assessment is done after the seizure is completed. So, first of all, we of course would want to make sure that the airway is patent. We would note the length of time before the patient regains consciousness or awareness. Note any presence of lethargy or confusion. Is there a complaint of headache? Is there a speech impairment? Does the patient have any muscle soreness? Was there an aura before the seizure began? That would be like a certain feeling or a sense of smell or something that's going to let the patient know that they're going to have a seizure. And then we're going to assess the effects of the seizure on the patient's vital signs. When we're writing out the plan for the patient, the expected outcomes are written for the individual patient, and the type of seizure disorder, possible triggers, and manifestations are noted. There, of course, are the safety considerations, and then patient and family teaching on what to do if a seizure occurs or how to prevent the patient from having the seizure. So, nursing care of a patient who just had a seizure includes which nursing interventions? Assess for injury, check the glucose level, reassure and reorient the patient, provide uninterrupted periods of sleep and rest, or provide a 24-hour sitter. Take a minute just to decide what are the correct answers. And the correct answer are to assess for injury, check the glucose level, assure and reorient the patient, and then provide uninterrupted periods of sleep and rest following the seizure. Okay, next we're going to talk about cerebrovascular accident, which is kind of an old term. Now we refer to it more as a stroke or a brain attack. The stroke is a leading cause of disability and the fourth leading cause of death in the United States. It's 19% higher in incidence in males than in females, and 34% of the cases occur in people younger than the age of 65 years. Risk factors for stroke. Modifiable risk factors would be cigarette smoking, using cocaine or other recreational drugs, drinking more than 2 alcoholic drinks for a male or more than 1 alcoholic drink for a female per day, heart disease, especially atrial fibrillation, diabetes, high blood pressure, high cholesterol, a sedentary lifestyle, high red blood cell count, such as in polycythemia vera, TIAs, or transient ischemia attacks, or use of oral contraceptives or hormone replacement therapy. Non-modifiable risk factors are age older than 65 years, asymptomatic carotid bruit, which indicates atherosclerosis, which increases the stroke risk, heredity, so a family history of stroke increases the individual risk. If they've had a prior stroke, we look at race. African Americans have a 60% higher risk rate of having a stroke. And again, gender, because it occurs more in men than it does in women. The pathophysiology of a stroke, it is a result of an interruption of blood flow to a specific area of the brain, which causes cerebral ischemia, and that directly causes cellular necrosis and infarct. Ischemia can be caused by a cerebral thrombosis or formation of blood clot, an embolism, which is a traveling clot or fat or bacteria that lodges in a vessel, an intracerebral hemorrhage. It's caused by blood vessel ruptures and leakage of blood into the brain tissue, or pressure on a blood vessel, such as occurs if the patient had a tumor. We need to teach people to seek immediate attention, medical attention, in the emergency department if any of the following warning signs of a stroke appear: sudden weakness, numbness, tingling or loss of feeling in the face, arm, or leg, trouble seeing in one eye or both eyes, or double vision, sudden confusion, slurred speech, trouble talking, or difficulty understanding what others are saying, a sudden severe headache for no known reason, sudden trouble walking, dizziness or a feeling of spinning around, a loss of balance or coordination, or a blackout. Should any of the warning signs occur, ask the person to smile, shrug their shoulders, repeat a sentence, or say what you say first. Tell the person who you are, where he is, or where she is. Stroke signs and symptoms. The signs and symptoms pretty much depend upon the location of the clot or the bleed, and what part of the brain is affected. So they can vary, quite significantly. So neurological effects of a stroke can range from mild motor disturbances to a profound coma, depending upon the area of the brain that's affected. If you look at figure 23-4, which is located again on page 533 of your textbook, it shows you the different body functions and sensory functions located in different parts of the brain. So there may be weakness or hemiparesis or paralysis, hemiplegia, difficulty and inability to speak or understand, dysarthria or aphasia, difficulty with vision, loss of balance, poor coordination, ataxia, decreased level of consciousness and confusion. The patient may experience incontinence, bleeding into the brain, or edema around the necrotic tissue from an infarct can cause increased intracranial pressure as well. Motor function deficits that occur with a stroke may affect mobility, respiratory function, swallowing, speech, gag reflex, and self-care abilities. Language disorders involving expression and comprehension of both written and spoken words can occur. Aphasia or dysphagia, or a mixed type of aphasia, may occur. Many stroke patients experience difficulty in speaking, otherwise known as dysarthria. Patients may experience emotional outbursts because of the frustration on not being able to do things. Also, the stroke may have an influence on the patient's emotions, so they may not be able to control their outbursts. Memory and judgment may be affected by the stroke as well. Their ability to learn may be affected. Spatial perception deficits may also cause the patient to totally neglect input from the affected side, which is called unilateral neglect state. Like if the patient has hemiparesis or hemiplegia on the left side, they don't even really totally recognize that the left side is there at all. Other spatial perceptual deficits: hemianopsia is blindness in the part of the visual field that affects both eyes, so they may not necessarily be able to see things to the left of their visual field. Other things that can happen: patients may experience bladder and bowel incontinence. Constipation can occur because of immobility and dehydration. And the patient may have inability to express their needs or difficulty in managing clothing, which could contribute to incontinence as well. How's a stroke diagnosed? It is diagnosed by an MRI or a CAT scan. An EEG could be performed. They may do transcranial Doppler flow studies and carotid artery Doppler flow studies to see if the circulation in the arteries is patent. They may test for blood levels of glutamate, which increases during a progressive ischemic stroke. And also a lumbar puncture may be done if they feel that there's a chance that there is a hemorrhagic stroke occurring, and they'll look for blood in the cerebral spinal fluid. What do we do when a stroke occurs? First of all, of course, we maintain an open airway. We administer supplemental oxygen. If breathing is impaired or the patient's comatose, we may insert an artificial airway to keep the airway open. Hypovolemia is treated with fluids. Hypertension of greater than systolically 220 over a diastolic of 130 millimeters of mercury is treated. If the blood pressure is lower than that, we don't treat the high blood pressure, because oftentimes as the patient settles down, their blood pressure will come down, and if we've already given them something to treat hypertension, it may actually drop the blood pressure below what we wanted it to be, and with the drop in blood pressure, that will decrease the perfusion to the brain, and it could cause some problems. So we don't treat hypertension unless the blood pressure is greater than 220 over 130 millimeters of mercury. If vital signs are unstable, then we need to, monitor that. If we need to give excess fluid because the blood pressure is low, we need to do that. Oftentimes we'll start normal saline IV. We assess the electrolytes frequently to prevent imbalances. If the temperature is elevated, hypothermia or cooling blanket may be used to keep the temperature down. And then measures to prevent deep vein thrombosis are instituted. If the cause of the stroke is determined to be a blood clot, active ACE, or some other systemic tissue plasminogen, is used to dissolve the clot and emboli in an ischemic stroke. It should be administered within 3 to 6 hours of the onset of symptoms. It has been estimated that this window could be met 28% of the time if a patient arrives soon enough after onset. Drugs are effective about 1 out of 8 patients treated. If TPA has been given, no anticoagulants or antiplatelet drugs are given for 24 hours. The drug is not administered to anyone with a known risk of bleeding or who has had an intracerebral bleed, because we don't want to cause more bleeding. Some strokes can be traced to an obstruction of one of the 4 arteries in the neck that supply blood to the brain. So the surgeon can open the artery and remove the obstruction, which is usually caused from a plaque buildup. The vessel wall is then sutured, leaving the vessel larger than it was before. In this slide you see an example of homonymous hemianopsia, where the shaded area is the area that the patient cannot visualize. So there's different types of hemianopsias. I'm not going to get into the specific types. You don't need to necessarily know each and every one, but just so that you realize that the patient's visual field can be impaired. So when you're working with your patient and they're coming in with a stroke, and they, let's say, have a left homonymous hemianopsia, number 4 on this slide, so they're not going to see anything from the left half of their visual field. You have to realize that when they first come in, if you come at them from the right side, they'll be able to see you. If you approach them from their left side, they're not going to be able to see you. So in the acute setting, you're going to want to approach them from the sighted side, so the side that they have vision from. Once they're transferred to a rehab facility, you're going to want to start training the person to look towards their left side. So you'll be approaching them from the left side, so you're starting to train them to compensate for their impaired vision by looking to their left side and turning their head. So that's kind of a clue as to the difference between acute care and a rehab setting, and how we adapt to their impairments after a stroke. Complications that can occur because of a stroke: extension of a hemorrhage or a rebleed may occur. So the initial symptoms are caused by, let's say, a leaking aneurysm, a rupture. Neurological signs and level of consciousness are watched closely to detect if there's any deterioration. The patient is kept as quiet as possible. The patient may, be fine and stabilized, but we continue to check their neural assessment, for the next 24 to 48 hours to establish whether or not they may experience an extension of their CVA. So all of a sudden they'll start having some further impairment of their neurological status. Another complication is seizures are common in patients who've experienced a stroke because their neural pathways are interrupted when the blood flow is blocked, or there's an irritation from the cerebral cortex because of an intracerebral bleed. So the type of the seizure depends on the area of the brain involvement. Generalized seizures may occur. So patients then are started on anticonvulsant therapy to prevent any further occurrence. Another complication of stroke is hydrocephalus. If blood is leaked into the ventricular system of the central nervous system, it interferes with the reabsorption of cerebral spinal fluid, and this can cause hydrocephalus. It's common when there's a subarachnoid hemorrhage, and it may be necessary to prevent increased intracranial pressure by shunting the fluid out of the brain. So that would be done in an intensive care environment. So there's 3 phases of care for a patient who has a stroke. Phase 1 is the initial phase. Okay. Phase 2 is concerned with rehab efforts, and phase 3 is during which plans are made for continuity of care once the patient returns home. So let's first look at phase 1. So immediate assessment of breathing and respiratory rate is done. Level of consciousness is also assessed. The initial care of the stroke patient includes careful assessment to determine the extent to which neurological functions have been affected. Complete hemiplegia is a common effect of stroke. Aphasia often indicates ischemia of the brain cells on the left side of the brain and is usually accompanied by right-sided hemiplegia. If you look at figure 23-7 on page 536, it illustrates the deficits that are often experienced by patients who have damaged left or right-sided damage of the brain. So if the patient has left-sided damage, in this picture you can see if the patient has left-sided brain damage, they will have slow, cautious behavior. They may have speech problems, aphasia. They have difficulty in following verbal commands. They have apraxia and difficulty in performing simple tasks. And they have right-sided hemiplegia. Okay, so if they have left-sided brain damage, they have right-sided hemiplegia. If they have right-sided brain damage, they are quick and impulsive in behavior. They have a short attention span. They neglect their left side, so they don't realize that it's even there. They are easily distracted, and they have left-sided hemiplegia. So if they have right-sided brain damage, they have left-sided hemiplegia. So as far as nursing diagnoses for the patient who's in phase 1, let's see, potential for injury due to weakness, paralysis, confusion, decreased consciousness, or unilateral neglect. There's altered physical mobility due to weakness or paralysis. Altered nutrition due to impaired swallowing and hemiparesis or hemiplegia. Altered self-care ability due to inability to perform activities of daily living, feeding, bathing, grooming without assistance. Altered urinary function to neurological deficits. Altered bowel function due to impaired mobility and neurological impairment. Potential for altered skin integrity due to decreased mobility, paresis, or paralysis. Altered communication ability due to inability to clearly verbalize or inability to comprehend communication. altered body image due to neurological damage and hemiplegia, altered sensory perception, visual due to loss of vision in parts of the visual field, and kinesthetic related to decreased sense of touch on one side of the body. There's decreased self-esteem due to alteration in body image and due to dependence on others, altered coping ability due to loss of usual lifestyle, neurologic deficits, and dependence on others, and potential for injury due to a lack of sensation in the extremity. Planning for specific goals should take into account the individual patient's previous lifestyle, age, general health, or illness status. An 80-year-old retired person may not have the same goals for rehabilitation as a 47-year-old mother of 3. So major nursing goals for the first phase are: maintain an adequate airway, establish baseline data regarding vital signs, level of consciousness, neuromuscular function, and neurological status, preserve joint and muscle function, and prevent complications that may interfere with rehabilitation. The amount of activity permitted a stroke patient during the initial acute stage of her illness depends on the cause of the stroke. If there's a danger of continued hemorrhage from a ruptured artery and resulting increase in intracranial pressure, physical activity will be limited. When there's no danger of further damage to the brain, the patient is usually encouraged to become active as soon as his condition is stabilized. Many patients have dysphagia, which is difficulty swallowing after a stroke, so the speech therapist should be called in to do a swallowing study and then to devise a plan to help improve swallowing. Evaluation is based on whether the interventions are effective in achieving the expected outcomes. So it's necessary to assess whether the overall goals have been met. If the goals haven't been met, then the care plan must be revised. Okay, phase 2. Plans for rehabilitation began the moment the patient is admitted to the acute care facility. So again, maintenance of adequate airway and aeration of the lungs, proper positioning, range of motion exercises, etc. are done with the thought that the patient needs this assistance until they're able to maintain them on their own. If disabilities from inactivity are prevented, then rehabilitation has a much better chance of being successful. During phase 2, we have many members of the healthcare team collaborating with the patient and the family to put together a plan to resolve psychosocial and physical problems. The team members include physical therapist, speech pathologist, social worker, psychologist, and occupational therapist. The patient is usually transferred from the hospital to a rehab facility after their neurological status is stabilized and their vital signs have been stable for at least 24 hours. Stroke patients can be prone to rapid mood swings and spontaneous crying. So all healthcare workers should be patient and explain what's happening to the patient and the family to help ease the patient's embarrassment. Then in the phase 3 of care, plans are made for discharge and referrals are made to agencies outside the hospital or rehab setting that will help the patient and his family to adjust to the new way of life. Oftentimes, home care nurses are assigned for a period of time to help coordinate the rehabilitation efforts and assist with teaching and assessing the patient's status. The patient will continue rehabilitation in an outpatient setting under the healthcare provider's supervision. Let's now look at infectious and inflammatory disorders of the nervous system. The first infectious disorder is bacterial meningitis, where it's the inflammation of the membranes covering the brain and spinal cord, and it's caused by, of course, an infectious agent. It may be virus, maybe a bacteria, or it could even be caused by a fungus. Fungal meningitis usually occurs with AIDS patients. Because infectious agents can be carried through the bloodstream to the membranes of the coverings of the brain and spinal cord, brain tissue can become affected by an infection in particular areas of the brain. From there, infection can also spread to the spinal cord and the sinuses of the brain. Many different types of bacteria cause meningitis, but the main bacteria is Streptococcus pneumoniae or Neisseria meningitis. Meningitis vaccines are available and required for students entering college. It's recommended for all adolescents and others at increased risk for meningitis. It should also be encouraged for adults living in a communal situation, as meningitis can spread quickly when people are living in close proximity, such as in classrooms or dormitory rooms. Signs and symptoms of meningitis are a sudden onset of fever and a severe headache that is greatly aggravated by moving the head. Other signs of meningeal irritation include pain and stiffness of the neck when flexing the neck, otherwise known as nuchal rigidity. A positive Brudzinski sign can be elicited by placing a hand behind the patient's head and with the other hand on the chest gently flexing the patient's neck forward by moving her chin toward her chest. If there is flexion of the knees and hips when you try to flex the neck, the Brudzinski test is said to be positive and indicates meningitis. The Kiernig sign is where you have the patient supine again, and with the hip and knee flexed at a 90-degree angle, slowly extend the knee. If you look at figure 23-10, which is located on page 544, this might help you visualize it a little bit better. But if there is pain, not just discomfort, behind the knee, the Kiernig sign is said to be positive, indicating again meningitis. Seizures are also typical, as are nausea and vomiting with meningitis. So quick intervention, medical intervention, is necessary to prevent death. Diagnosis is made via a spinal tap, and the cerebrospinal fluid is examined for the number and type of organisms present. The success of treatment of meningitis depends on early recognition and prompt treatment. Antibiotics can be started immediately for bacterial meningitis, and when the causative organism has been identified, a specific antibiotic to which the organism is sensitive should be administered. A combination of 2 antibiotics is often common. The disease usually responds well to IV antibiotics, followed by oral doses given for a total of up to 10 days. Dexamethasone has proven beneficial to decrease the inflammation, and anticonvulsant drugs are administered to control seizures. Ibuprofen, aspirin, or acetaminophen is given for headache. Let's see here. For viral meningitis, is usually caused by enteroviruses, HIV, or herpes simplex virus. It usually tends to be milder than bacterial meningitis. The initial signs and symptoms include headache, fever, photophobia, and stiff neck. Brain involvement symptoms are very uncommon. The CSF is examined via lumbar puncture to confirm the diagnosis. A complete blood cell count also is done, and you'll see an increase in lymphocytes, in the lymphocyte count. The disease itself is pretty self-limiting, and treatment is just basically trying to manage symptoms. Full recovery typically takes 7 to 10 days. And some of the residual effects are persistent headache, mild mental impairment, and lack of coordination. Okay, the expected outcomes for patients who have meningitis would be to conserve the patient's strength, prevent seizures, and promote healing. We would use standard precautions and droplet precautions to prevent the spread of the infection. The patient's room should be dimly lit, should be quiet, to decrease stimulation, because the stimulation and more input will activate nerve impulses and cause the patient more discomfort. Now let's look at other brain disorders. First one we'll look at is headache. Headache is the most common cause of complaints of pain. It's commonly caused by an allergy or sinus problems or by tension, or it could be vascular in origin. Treatment for severe recurrent headaches begins with determining the cause if possible. Mild headaches usually are relieved by rest and maybe a mild analgesic. Migraine headaches affect mostly women. It's believed that a constriction and subsequent dilation of the cerebral arteries causes a migraine headache. Attacks usually occur irregularly and may begin with an aura, such as a visual disturbance or spots before their eyes. Many patients with migraines do not have auras preceding the attack. Pain usually begins on one side of the head and is described as throbbing in character. A migraine can be accompanied by nausea and vomiting. Symptoms may last for 4 to 72 hours. Light and sound can cause irritation and sensitivity for some patients with migraines. Frequent migraine headaches can become very debilitating. Lying in a darkened, quiet, odor-free room with eyes closed decreases the symptoms. Various behavioral treatments such as biofeedback, acupuncture, and relaxation therapy combined with lifestyle adjustments and medication seem to offer the best result. Medications that are given for migraine headache are vasoconstrictors such as enapsin or Thorazine. If you look on page 554 of your textbook, box 23-2 lists medications that are used for migraine headache treatment. And drugs that treat the actual migraine symptoms are listed initially, and then the preventative drugs that are taken daily to prevent the occurrence of migraines are listed then towards the bottom of the box. Again, I wouldn't necessarily expect you to memorize the whole list, but just take a look at it so you're somewhat familiar with them, because a lot of our patients will come in and maybe they'll be on metoprolol for headaches or propranolol for migraines, and that helps you to understand, why the patients are taking the medications that they are.